please help spread the message of Frequency Specific Microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about Frequency Specific Microcurrent.
While I was in Poland, on my 7 terabyte laptop, the operating system crashed, failed.
Oh.
I had no laptop. So I used Eduardo's slides and Eduardo's computer to do this seminar in Italy. And then I came home, and my big desktop up here that I figured would be just fine, it did something very strange and weird too. So I had no computers, zero, for a week. It was awful. And
That
it was
sounds almost like
good.
that's my first feeling, that it might have been a little nice for you to unplug for a little bit.
It was.
You know, they're necessary evils and we absolutely need them. But
I knew everything would be okay because of rule number 1.
Yeah.
What you need shows up. It just doesn't always look like what you thought it was going to look like.
that phrase, you've given epic advice over the years that I've known you, but that one always really, when I start, and I think anybody who's a little type A that likes to control, that is also a
Perfectionist.
sole proprietor of their business owner, we love to control as much as we have to. And I think a lot of times we do have to take on that ownership role, otherwise things fall apart.
Sure.
But that can also give a lot of rumination and anxiety, and we have so little control over a lot. But that phrase gives me so much comfort to know that, no, you're not spiraling in the abyss of despair. What you need will show up.
It just doesn't always look like what you thought it was going to look like.
And that gives so much flexibility to, and we've talked about this so many times, how FSM gives us that flexibility of mind where we don't get hung up on the diagnosis or the hypothesis. We have to be able to pivot and adapt. However, we have to be open to
Creative solutions. I like that one.
Netters is good for so much besides just learning.
And it was the original Ciba Geigy. The way Netters started was he had a contract with a drug company, Ciba, CIBA,
Okay.
and then they merged with Geigy, so it's Ciba Geigy. So there's the Ciba collection, the nervous system, 1 and 2, the endocrine system, the heart, kidney, ureters, and bladder. There's a whole book that thick with Netter drawings and his words. Digestive system, musculoskeletal system, digestive system 2, and respiratory system. There's a separate book for each one.
Wow.
And George had the whole collection. I had one of them.
I feel like 2 little kids that have found each other on the playground and we're just like holding hands and like spinning around in circles because we have so many secrets to share.
Yeah, exactly. There we go. Hi.
You look great. You look tanned. You look rested. You did amazing things overseas. I don't go on the Facebook profile as much as I should, but you always direct me there when something epic has been posted. It sounds like you had an amazing time in Italy at the practicum. What I love about you, I'm just going to start the show by saying this, is that you get just as surprised and in awe with what we do as a new person does.
Oh, yeah.
And that's amazing. In such great ways, right? Can you imagine just being in a job where you are just bored out of your mind and nothing new or inspiring comes to you?
No.
Or you think you know it, or you've hit the ceiling, or you've plateaued, or
Well, you take it for granted. If you're an auto mechanic and you're fixing a 1991 Nissan, there's a book that tells you exactly what's going to happen and exactly what you're going to do. With FSM, I never take it for granted because the human system is so complicated.
Yeah.
And we have simple fixes. So yeah, full body pain. Okay, that's 40 and 10. That's easy. Good news is he didn't have tight legs, so that was that. He had lumbar spine surgery that didn't help. And as soon as they fused the facets, his pain got worse. So they took the plates out. So he had wicked low back pain, and he had wicked pain in between his shoulder blades and wicked low back pain.
All bilateral?
Oh, yeah. And he was, I would post a picture of it. I still have to put that on Facebook at some point. And he worked out every day. The original injury was when he was 19. So he's 37 now. So for 28 years, he's been at between a 6 and a 9 forever, lumbar spine surgery. And then I thought I should check his psoas. So I go to check his psoas, and you can't get past his abdominal fascia. Well, I don't care what kind of six pack somebody has. When you slide off the rectus, what happened to your abdomen? Oh, I had appendicitis and it ruptured and I got peritonitis. So I did scarring in the abdominal fascia, and then I could get to the ureter. And when I did scarring in the ureter, his low back pain went away. We had 6 machines, subacute facets back to abdomen, 40 and 10, concussion in vagus, disc repair on his neck for the pain in between his shoulder blades. His Babinski was negative, so I could polarize things. And then 13 and 16, concussion in Vegas. And he didn't have fibromyalgia because he worked out every day. He was so buff.
Right.
Big muscles everywhere. And it's, whoa, dude. And when we were done, I didn't run 81 and 92 because we were out of time. Eduardo and I taught him to walk toe heel, toe heel, toe heel to get it to his brain. And he only spoke Italian. I was a gait belt for 15 feet, and then Eduardo took over and walked him up and back and up. And then he smoothed out, and I said, okay, now walk normally. And the smile on his face still gives me goosebumps. And I never take that for granted. There's never any guarantees that you're going to hit all the numbers. The next day he came back. He had to drive 2.5 hours to get there. Came back, and his knee, when you flexed his knee, it stopped at 90 degrees and his head popped back. Dural adhesions. Supine cervical, did scarring in the dura at the base of his skull, and then neck to sacrum. I put Eduardo was at his head because Eduardo is a cranial osteopath. And we got his knees pretty close to his chest. And then he said, I can feel it in here. So you're running scarring in the dura. And I said, okay, now take a deep breath, hold it, and bear down. And then Eduardo translated that into Italian. And then we peeled his skull off of his dura. The shape of his head changed. And when he got up to walk, his gait was completely different. It was so much fun. And 40 and 10 never came back because the disc is already healed. He started out with a disc in his neck. The disc is healed. He's got pain between it. No, it wasn't. The spinal cord is healed. The disc in his neck is still wonky. But the physical therapist in the class was the one that brought the patient to be treated.
Okay.
And when he got up off the table at the end of the first day, the physical therapist is in tears. I said, what's your pain level? None. So we had one machine running on 40 and 89 for about 10 minutes until that funny look went away. And the class in Italy, Eduardo got 50 hours of category 1 CME credit. We had 5 MDs in the room, 10 PTs, scattering of naturopaths and 1 acupuncturist from Belgium. And the lady from the accrediting agency, the one that approved the CE credits, they always come and sit in on the class for half a day. She stayed for 4 days. She couldn't leave. She just kept coming in and sitting in the back row, taking notes, watching. It was amazing. It was so much fun.
What is that we have that deep sigh after, right? Because I think, I mean, I hang on every word that you say, because as a practitioner, you're replaying it. If this person came in to see me, what would I do? Where would I start? What would I look for? And when you have an intimidating history or even an intimidating presentation, somebody who looks really healthy but has so much pain, like that is not congruent. And our traditional allopathic medical system can't put that together. You look healthy, you're obviously not in that much pain because you're going to the gym every day. People don't understand that concept.
Yeah, they don't get the neurology of it. What he did by exercising was he kept his growth hormone up and he kept his oxytocin up.
Mhm.
And that keeps you from turning full body pain into fibromyalgia. And we did patellar reflexes. They were +3, but his Babinski was negative. So that gave me the chance. It was such a wonderful teaching opportunity because scrape the bottom of his foot and his toes go down. Okay, that's a negative Babinski.
Right.
And then I knew it was okay to polarize 40 and 10 positive because there wasn't cord compression. And it also told me that the disc was safe to treat conservatively, to use disc repair and exercises. So because his low back facets were so bad, I had to teach him the multifidi, the multifidi exercises that we do with the patient prone.
Yeah.
Well, you can't take somebody with horrible facets and lay them on their stomach. So we had him figured out that you can turn your head and push it straight back into the table and get the multifidi to contract. And I said, that's how you repair the disc. So he
What?
bought a custom care
Yeah.
for himself.
Yeah.
The physical therapist bought a precision care.
Very good. That only makes sense.
It just made perfect sense. It was so cool.
Yeah. I have so much to unpack with what you said. I need my pen and paper so I can take notes as you talk. This person that you're talking about, so reflexes, did he have numbness or tingling anymore? So
Just a central, and he didn't have tight legs.
that was the other follow-up. Okay.
No tight legs, only pain. He said the pain in between my shoulder blades. And I said, is it right here? And he said, yeah. His biceps reflex on one side was like not great. And I turned to the class and said, he has pain between his shoulder blades. Does it have anything to do with his shoulder blades? And they went, no, because by then they'd seen the Cloward drawing 6 times and they remembered it. I was so proud.
And this is a traditional person that would say, I have pain between my shoulder blades. Somebody would say, oh, you have tight rhomboids, and would just mash on them. And
Yeah.
that's wrong for so many reasons, because nobody has tight rhomboids.
Nobody.
They don't. And I say this story in the sports. I've seen one pair of quote unquote tight rhomboids, and it was an Olympic level backstroker.
Oh, yeah.
How many Olympic backstrokers do you see?
I've never seen any. I would send them to you if they ever came to me and said, yeah, you don't want to be here.
My point is that we don't live in retraction. So for a muscle to be tight, it has to contract. And anyways, they're stretched and they're weak and they get trigger points. But did you discern from this patient what the onset was? Or sometimes we have to go way back and find something in the history that helps us unravel. And sometimes we have to treat what we see and then we'll deal with the history later, but let's just get you out of pain, right?
History was very precise. And it was when he was 19. So he was fine. And then there was an event when he was 19. And I can't remember if it injured his low back. I think it was his low back. That was it. So he hurt his low back. And I don't remember if it was a fall or whatever. But once he lost the ability to go into extension, his head went forward. So the disc in his neck was creep, was postural. It was the way he held his head, because he had to be, in order to take the pain out of his low back facets, he had to be in a C, right? So if your head is down like this and you're doing that, you have constant tension on the jelly donut that is the disc,
Yeah.
because he had no other auto accidents, he had no other trauma, but he had full body pain. So he cracked the disc when he was 19.
Right.
And at that time injured his lumbar facets. And then he had surgery when he was 25 or 27 to fuse the facets. As soon as they fused him, his pain got worse. So a year later, they took out the plates and screws. But he couldn't stand up straight. So he was always in a C, because I couldn't figure out, why do you have a disc bulge?
Mhm.
And then I looked at his posture, and his ears were 2 inches forward from his neck, from his shoulders. So it's okay. So the trick was to get him to contract his lower traps. And he's so kinesthetic, because he's at this point a bodybuilder.
Yeah.
I could pinch them, and Eduardo could say, bring them down towards your belt. Once he got his lower traps to contract, then his upper thoracic paraspinals fired, and he went into neutral, and his mid-scap pain was gone. And I don't have my phone here, so I don't have that thing that I wrote that I sent you. We need to post that.
Could be its own slide at the advance. That could be its own podcast, to be honest.
Yeah. All I can remember is saying, I challenge you to accept and promote what we do. I've wanted to keep a low profile for so long. And when we were in Poland, one of Kasia, the lady that promoted, we had 44 students in Poland.
Amazing.
PTs, naturopaths, acupuncturists, MDs, lost the train of thought.
What you were saying, I challenge you to promote it. You want to keep a low profile.
Oh, and so she said, in our world, miracles are normal. What we do is impossible.
Yeah.
And don't make promises, just fix one patient at a time, change medicine one patient at a time. And when you change even one patient's life, you change the world. And if you're not here to change the world, what are you here for? In Rome, the whole class just went gulp. If you're not here to change the world, what are you here for? And do what you do it with skill, but tell people about it, publish it, advertise for it, go for it. Don't make claims, because you get in trouble for that. Now I remember part of it anyway. It's on my phone someplace.
Yeah. This is a very organic and natural segue to one of the things I wanted to touch on. So I had very profound interviews with Jen Sosnowski and David Mesnick.
Oh, yay.
And I love having them on because they're just these fountains of information. And I've gotten better, I think, as an interviewer, where I can streamline it and I say, this is the one topic we're going to choose. And I'm going to keep bringing you back to this topic if you go off. You and I can go over, because I get you pretty much every week, provided that you're not in Europe and Kevin's not accessible. We can't get on here. But so I'll talk about Jen in a second. And Dr. Musnick and I were talking about the power of words and what we say to patients and clients and what they say to us. And he wanted to do a whole talk just on that, like mindset. And I said, no offense, I did mindset with Peter Twist, and that was great, but we need your brain for your brain. And we'll talk about it a little bit. So we talked a lot about autoimmunity, but with that was how he promotes patients with tapping and mantras and affirmations, because Words absolutely matter. So one of the stories, we had a really neat California hybrid class. I think it was a month ago, it was in August. So that's almost 2 months ago now. And we had some of the Bay Area's brightest PTs. It was I would like to do more of these actually, these kind of like half day or 1 day, like in services where it's like the master class slash study group. And we in the room decided that we need to rename 124 because it's a scary sounding. And if you just put 124 on something and you said to the patient, I want you to run torn and broken on your connective tissue, especially the athletes can get worried about torn and broken. So they came up with the phrase repair and heal.
Repair. I like that.
It's doing what it's supposed to do, but sometimes those words, and everybody deals with words a little bit different. Since day one, I had to rename concussion protocol because I work with so many hockey players. That is the true C word. For normal patients, it might be cancer. For athletes, concussion is an extremely scary word. So I'm not about to tell them Harry Van Gelder's model for concussion. They just need to see something that resonates with them for what I want it to do. So it was neurocom or something that was like, okay, this might help me relax, or this is what I'm going to run at night because it felt really good.
Balance.
Brain balance, exactly.
Either,
Yeah.
because otherwise patients think they have to have a concussion
Yes.
to do it. Speaking of repair, as soon as you're finished with this riff, Louise has a question that is absolutely relevant to something we did in Italy that was just amazing.
Let's go there. I can get this bus back on the route very quickly.
Okay. Louise, Dupuytren in French is disease. No. Which conditions and tissues to treat? Inflammation, fascia. Yeah. So have you been able to make the nodules soften?
Okay, stop. I'm going to pause you.
Right.
People that are driving on the freeway right now, we need to unpack what a Dupuytren's contracture is. First of all, they can't see your hand.
So the tendon, the flexor tendons, usually the little finger and the ring finger, get
shortened or
tight and short and glued together, and contractured is the word that medicine uses. One of the practitioners in the class came with his little finger and his ring finger, and this flexor tendon just at the fifth MP joint, metatarsal phalangeal joint, was about 7 millimeters across, really thick and hard. So to answer Louise's question, I did 58s, I did scarring, 217. It's calcium and hardening and scarring. And it's a round tendon, but when you look at Netter for the hand, there's a connective tissue lever arm that allows the tendon to bend the finger. So we got the thickness of this tendon down by 70%. And then Eduardo being Eduardo, and we both are looking at it, and I said, look at his, so these are flexor tendons in Dupuytren's that are contracted. What are they attached to? They are attached to the flexor wad in the forearm. And I felt up the flexor wad, and the whole flexor wad was like a brick, which brought me back to what we talk about with the shoulder. When the muscles are really tight, when there's a partial thickness tear. It also works the other way. If the muscles are really tight, it will cause a partial thickness tear in the connective tissue attachment at the elbow. So we went 124. He just sat there in class and ran it for an hour. And at the end of that, the flexor wad was soft. But then we got to his biceps, and his biceps was tight. Okay, if you're doing this flexion all the time, your elbow is, he couldn't straighten his arm and put his hand flat on the table.
Hmm.
You can't straighten your arm. That means the biceps tendon is torn and broken. So we ran torn and broken in 191 because the biceps tendon at the elbow is round. And he ran that for an hour. And then during one of the practicums, his team took apart scar tissue in the brachial plexus under his arm, down the radial nerve, down the ulnar nerve, down the supinator, took scar tissue apart. This thing where he said, it's in my hand, ended up being in his hand. We had to treat that first, but then it was the flexors, then it was the biceps, then it came all the way back up to here. And at the end of 5 days and probably 4 treatments, he could lay his hand flat on the table and straighten his elbow.
Right.
Who else can do that?
No, I know. I think part of it obviously is FSM itself, but the other part is thinking what connects to what and what's involved with this. And if this is tight, what else could be reacting to, what is its neighbor doing, so on. It's being very myopic, but also looking at the more global, expansive picture of what those adaptations have caused.
And I have to give you credit for part of my thinking about that. Everything's connected to everything. But the last thing we had to do was 40 and 89 as he straightened his arm.
Yeah.
Everything's connected to everything. And it's all your fault.
No, let's share the blame. It's been collaborative. But how you were saying what you need shows up, it's just not always what you thought it would. For whatever reason, and I feel like there's always a theme almost when you think back of certain years, wow, I saw a lot of ankles, or I saw a lot of shoulders, or I worked with a lot of athletes, or I saw a lot of fibromyalgia. There's a pattern that's there that I really feel like is in place for me to learn from. And I remember my father gave me a lot of terrible advice, but he also gave me some very good advice. And one of the most profound things he would always say is, if you're the smartest person in the room, you need to find a new room. And that was his not so subtle way of saying, you're always supposed to be learning, right? There's always something to. Right now, my season went from a very big, multifaceted clinic in Canada to me working very one-on-one and solo. And I miss that collaboration. And a couple of weeks ago, I was really thinking maybe I need to go back to a big clinic or work with people. I love collaborating and getting different ideas from people. And then I thought, you're still learning, because the people that come in and are like, why doesn't my shoulder blade move? Or why am I afraid to do this movement? That's where I get to learn. I'm relearning my clinical anatomy and biomechanics every single day. And part of the season, I think I've been in the path in the last 2 years for sure, and COVID really expedited this with everybody, is this need for safety. And that's where 40 and 89 really took a place in my heart, was we are doing things at lightning speed sometimes. This is not what any of us are taught in our training, how fast we can undo scar tissue, how fast we can recruit a muscle that hasn't been online for so many years. And we have to respect the fact that the client on the table or on the floor or wherever you're meeting them also cannot compute how fast these results have taken place. And for any movement to occur, and our job is to do a great treatment, but I think our job is to promote lifelong tools to help somebody. Like you said a couple podcasts ago when I was on the road, like, we are not healers, like, we're facilitators.
Yeah. That's the other fun thing about FSM, speaking of find another room, is I've never successfully treated Dupuytrens before, ever. I've seen 5 of them in 30 years. And they're incredibly frustrating, partly because the patient waits too long until the distal and the middle joint fuse. Then it's difficult. This guy still had movement in the distal finger, but this tendon was thick and hard. And Louise said, is it dehydration? No, it's genetic. He may be the only one in his family that has it because it's a recessive gene. So he's got 1 chance in 8 of getting it. And all he had was, it was double recessive. And that's, but he didn't wait too long. And finding out that it wasn't just 217, it wasn't just hard, it was scarred. When you look at Netter, it was scarred to the underlying nerve.
Right.
Never would have thought of that.
No.
And this tendon is not going to let go until you pry it off of the ulnar nerve.
Right.
With FSM, because we have a tool that lets us do things like that, the room is always big. Because this little thing, I had to do this first. If I couldn't do this, then there was no need to do the forearm flexors or the biceps. And you have to think in 3 dimensions. So it's always a challenge. But that's a great line. But that's the thing that is magic about FSM is the room is always big.
Room is always big. And that kind of goes back to our very first, my very first things that I was saying, like how amazing that you've been doing this for so long and your eyes still light up. It's because we're lifelong learners. And if you approach it like that you always have something to learn and to grow, you will always see those opportunities to learn and to grow. And instead of just treating a Dupuytren's contracture locally and trying to like, I'm just thinking of before FSM, it would be just cross fiber friction it, just trying to like.
Which makes it worse.
It makes it worse because you're getting more inflammation, which creates more scar tissue. And this we know. But then again, like looking at it in a different light, if sometimes the muscles get tight and then they pull on the tendon and that creates a bone spur, that creates a tendinopathy. In this case, this isn't the case, but you still had the foresight to look down to the muscle belly because of course your body will never create excessive laxity. There'll always be, the word seems to be adapting today, adaptive shortening. So your body will take up the slack. So there's always something to treat when you think of it that way.
The beginning of this tendon in your finger is at your elbow.
Correct.
So once this tendon was scarred down and short, the flexor wad had to shorten to protect this. But once it was so tight for 5-10 years, the tendons would get strained,
Sure.
tendinopathies, and that would tighten the muscle even more. So once we got this loose, we had to repair the tendons to get the muscle to relax. And once the forearm flexors relax, that's when the increased tone in the biceps showed up.
Right.
It wasn't even obvious until the wrist, the hand, and the flexors, and then he couldn't straighten his arm. Well, that's torn and broken. That's a round tendon. That's a different one.
Yeah.
The team at his table will never forget that one.
No, what an amazing thing to see at your first core.
Yeah.
It's funny, just a quick story, just going back to this. I was doing a consult peer-to-peer, the group call last week. And there's a bunch of us on the call. I'm like, okay, Kim, we have this tendonitis and blah, blah, blah. I'm like, okay, is it a tendonitis? Yes, of course it is. Is it a tendinopathy or could it be a tendinosis? What are you talking about? I'm like, think about it.
It's in the core. One slide.
But these aren't people that have taken the core in a while.
Oh, yeah. Good for you. That is great.
But in normal, everyday, non-FSM world, you can get away with tendonitis, tendinosis, tendinopathy because that suffix doesn't necessarily mean, that's not the game changer. It's going to be an anti-inflammatory, it's going to be a muscle relaxant, it's going to be whatever it's going to be. But these are huge pivotal adaptations that we make with our A channel. And then I said, okay, fellas, is it even the tendon? What? Could it be the periosteum? Could it be the fascia? And they're just like, okay. I'm like, little voice, this is why we're calling her, okay? Don't make her mad. I'm like, I'm not mad. I'm just trying to open up the possibilities.
And the only reason we know, the group mind, the hive mind in the FSM world, the only reason we know, I knew, about that tendonitis doesn't exist. It is never, ever an itis because the immune system is not involved. It's not that the immune system is attacking the tendon.
Right.
It is a tendinopathy because when the tenocyte, the tendon cell body, recognizes that there is a partial tear or a tear in the tendon that it can't repair in 24 hours to 48 hours, the genes inside the cell change and begin to express the genes for interleukin 1, CGRP, substance P, and it's trying like crazy to make connective tissue, but it's down there at the tendon cell body. So when you have an Achilles tendinopathy, Achilles tendonitis, opathy, it gets thick like two thumbs.
Right.
And when we treated 124, which is no longer torn and broken, what is it? Repair?
Heal.
Yep. Okay. So when we treated 124, all that just disappeared. And it's when thank you, Diana Cross, it's when I learned the way FSM works is by changing cell signaling and thereby changing the genetic expression inside the cell. It's the only thing that explains how you can take a tendon from two thumbs to a little finger in 60 minutes. It's how we think about it.
Because the tendon, when it is thickened like that, and that's, if we're going to use an Achilles as an example, it's not inflamed. It is thickened. It's almost hypertrophied. It's grown in size. So that's not just swelling around a tendon.
And it is inflamed, but it's inflamed because the tendon cell body is releasing interleukin 1 and CGRP, which are inflammatory. So the tendon is inflamed in that spot, but it's not like rheumatoid arthritis or a cold.
Right.
It's the immune system causing inflammation. Every cell in your body has the genes to turn on to cause that cell to release inflammatory products. Every cell.
Yeah.
Cut yourself and it turns red. The tendon cell, the cell bodies in the skin change their genes and release interleukin 1, interleukin 6, CGRP. I don't know what the skin releases, but the genes change. And the only thing that makes any sense with FSM, because we get the changes so fast and because they're permanent, my Achilles never needed another treatment. It was done in 75 minutes.
Right.
Okay. We changed the cells, and as long as the epigenetics support the change we made, we're good. That was the other thing with the tall kid in Italy with the full body pain. The surgeons kept wanting to get at him. And he said, no, we're going to do this first. So went to the gym, changed his diet, and created an anti-inflammatory diet, started taking supplements, repaired his gut. So you have a 37-year-old male bodybuilder talking about healing his leaky gut. So he already had the stable state. That's why it was so easy to fix him.
Right.
So the epigenetics are what create the possibility for a lasting change. I swear that what we're doing is changing genetic expression in the cell. It's the only thing that makes sense given what we do and how it works.
This is what brought Dr. Musnick and I down the phrasing pathway, because a lot of people that are diagnosed not only with autoimmune, and we tried to keep Dr. Musnick's train on autoimmune theme,
Right.
but if you think of somebody with chronic pain, if you think of somebody with any type of lifelong diagnoses that is very vague, that has not a lot of hope attached to it, the world of epigenetics is very useful. So the book, The Biology of Belief from Bruce Lipton, has a beautiful new cover on it. It's a great audiobook if those of you want to listen to it. Explains this world. And as Dr. Musnick said, like, the autoimmune slap label is not a death sentence. There is so much you can do with your, however we want to phrase it, stable state, the cellular environment, to create change, and to know that change is possible, and to know that you have power over much more than you think you do.
If you can turn on the vagus and heal the gut, you can minimize an autoimmune condition. And it may or may not go away. You can't put tissue back that's not there. If you've had RA since you were 12 and now you're 50, your joints aren't going to go back to normal, but you can slow the progression.
Yes.
Turn on the vagus every single day. Stop eating wheat, maybe, and milk. Those are good. Heal the leaky gut. David Musnick minimized my autoimmune disease. And when I went to Poland and there was literally nothing to eat that didn't have wheat in it, it sets off the autoimmune thing. And so I take extra baclofen and know that once I get back on my diet, or once I get to Italy and I can eat wheat, I can bring it back down again by turning on the vagus.
I'm going to go back to where we started again, is giving the patient or the client control or power over whatever it is, the condition, pathology, biomechanical dysfunction. And to, again, going back to what, like, jump on the rooftop and scream what you're doing, absolutely. But know that you're not the healer, and they have the power to hold whatever gains that you have created together as a team. It's like the Wizard of Oz, right? Dorothy has her ruby slippers, and it's like you've had the power all along.
The body has the power. This is Thad's comment.
I want to say this out loud because it's beautiful.
Yeah.
Tad says, I'd like to think that FSM is speaking a language that the tissues already understand. Therefore, appropriate verbs are implied with each of the mnemonic candles for the frequencies. Mostly the verb phrase, tissue X, please remove the effect of, works for me, except for in a few, please repair, or please dissolve, please increase, and so forth. And sometimes the client's ears need to hear these verbs too.
I always explain what I'm doing while I'm doing it, unless it's too scary. Depends on the emotional state of the patient.
Absolutely. Yes.
And then the other thing I always do is reach up and feel your neck. So it softens, because that way the sensory cortex has a kinesthetic experience of, my neck is soft and it doesn't hurt. Reach over and feel your right arm. It's soft. So that communication, the client's ears and the client's brain need to connect with their new state of being.
We talked about mantras with Peter Twist and with Dr. Musnick, and my 3 phrases that everybody has to say at some point and in some sort of place during a visit with me is, I am safe, this feels strong, movement feels good. And whether or not they say it out loud, or I just have these phrases for them to just hold in their head and take a few deep breaths, because movement can be extremely traumatic. Somebody who's been in a standing fetal position because of trauma, moving it to extension, or what we call a cactus in yoga, is completely vulnerable position. And historically, going into extension is not a safe movement pattern anyways.
Especially if your ureters are scarred to your psoas. There's no way your brain is going to let you go into extension.
Oh.
Once you take scarring out of the ureters, the kidneys, and the kidney fat pad, and then they stand up, and then you show them to contract their lower traps. I'm taller. I'm going to add one thing. Those
Yeah.
three mantras are awesome. For those of you that see really sick patients, especially patients that have had early childhood trauma, I don't know how to work it into the conversation because sometimes I just say it out loud, but the message is you deserve to be happy.
Oh.
When they've been abused from the age of 3 and you get them when they're 37 and they have been from an abusive home to getting bullied at school to an abusive marriage to a horrible divorce to single whatever, the whole concept of you deserve to be happy. What? Excuse me? And you do that while you're running 40 and 89 because it's the hippocampus that lives with the terror of
Mhm.
never being safe. I don't know how to say it out loud because you deserve to be happy sounds like something from Good Will Hunting, but it's maybe even holding that in your mind
Yeah.
is helpful. And Leaf said, experimenting with the constitutional factors, I stick with 6.8 and 38 just because it's safe and we're not going to turn anything on.
And I think in general, it's a very empowering, grounding. That's the effect it has on me. I feel like not only just in my body again, but in my body, ready to take on anything solid, strong. Like,
Everybody in the circle, where does there's the 20% that don't feel anything. And it's okay, there's 20 people in the room and there's only 2 of you, so 2 of you are lying. Where are the other 2 that don't feel anything? Okay, there. Good, thank you. It's always 20%. And the 20% that feel it pretty strongly, when you get to 6.8 and 38, where do you feel it? My feet, my knees, my butt. Though it's always lower extremities,
yeah.
and they always feel heavy.
Mm.
And it's like for me, when I run it, and I'm in the middle of the circle, not on the outside, they're an antenna. And so my feet get heavy. I
Yeah.
love 6.8 and 38.
So do I. It's just good.
Thank you, George.
It's a good one for the practitioners listening, that if your patients are feeling very floaty and they don't want to feel floaty, some people want to leave, they just want to float out of the room, and but some people don't quite like it and they need to go pick up kids and go grocery shopping and go back to work. And so 6.8 and 38, and I always do the 90-90 rule, have them sit down on a non-wobbly chair, so a hard chair where their ankles, knees, and hips are at 90, eyes can be in the horizon, and boom, that will sink them. Or have them stand in Superman pose can be helpful as well.
Oh, yes, I know. The Leaf is saying, yes, remember Soric in a extreme allergic situation, but those are in the advanced. And these days, it takes less than 40 minutes to do all of them because there are probably 10% of the practitioners are comfortable using the specific constitutional types.
Mhm.
And we cover them in the advance. I'm going to have so much fun in the advance this year. That was the other thing I was terrified about when my computer died. I have a Word document that is the beginnings of the advanced and symposium schedule. And once I read it down, I don't have enough RAM. And it's okay, who else is speaking and when? So my computer is in Montana now, and
Oh,
they will send me, yeah, data recovery. It was a thing. They will send me a jump drive with the the one thing we do need, because the 33 people who are listening today, I need case reports for the symposium. We need case reports. So it doesn't have to be anything exotic. Sometimes it's just the bread and butter.
yeah.
Well, what's in the room?
Yeah.
How do you do it? And 7.83, Derek says, yeah, George played Derek, don't know. 7.83 and 0, or if you're on a custom care, 7.83, 7.8 and 0.1. Because remember, when you're running channel A and channel B, you get each frequency by itself, but you get the sum and you get the difference. And with the Schumann resonance, it's very specific. So you don't know what the sum and the difference is going to do to the 7.83. So just a thought, you might want to consider just 7.8 and
0.
0.
Dr. Roger did a great. We have to do this again. I can't remember how many years ago it was, but he was talking about Schumann resonance, and there's a wonderful documentary on like EMF pollution. It's terrifying. You're going to want to throw your cell phone out the window after you see it. But James Russell is I believe it, and I think this is called Resonance. And you might have to Google it and find it on some sort of streaming platform. But the first 15, 20 minutes talks about the microcurrent that they had. They were projecting it in this bunker, and they talk about Schumann resonance. And so he talked about it at his talk, and then he's, let's watch it tonight. And we all went down in one of the lecture rooms at 9 o'clock at night, and we watched it. And I went down in my jammies, and so I
Where,
didn't.
at the advanced?
This was, yeah, many years ago. This
Oh,
might
it's in Las Vegas.
in Vegas. Yes.
There was one night where it was Roger and Neil Nathan,
Yes.
brothers from another mother, and they did the film on Lyme.
Yes.
It was that one. And then he showed the resonance one after that.
At a different night, maybe.
I don't know. Yeah. And Roger's coming this year. I'm so excited. Yay.
It is the geekiest family reunion that you're ever going to encounter.
And Neil Nathan has retired, and he's serious about retiring because he has moved a 3-hour drive away from the nearest small airport.
Oh,
So I said, you want to come to the advanced or symposium and talk about your new book? And he went, I'm not flying. I'm done. He
okay.
was really done. So we got Roger though. Yay. And Jay Shaw is coming. I'm
Oh,
so, and Juliana Mortensen and Mary Ellen Chalmers,
you really can't beat this all-star lineup.
and then Musnick and you.
Oh, remind me, we need to talk about Dr. Musnick's talk.
Okay.
This is like a side text. Sorry, everybody, you're just going to have to wait.
Yeah. He already told me the topics he was going to do. Did that change last week?
I don't know, but I have to talk to you about it.
Oh, okay, fine.
That's going to be good.
Fine.
I just Googled something really quick. So it is called Resonance. It is by James Russell. It was done in 2012. If you Google it, there's a little button that says watch movie. So there must be some streaming platforms, but it's phenomenal. I used to play it actually in the sports course, a little clip of it, because it does just talk about Schumann resonance and frequency, and it gives people who can't really understand what it is, it shows it in a very digestible format.
Wow. And when you think about what the earth creates this frequency, you've got this molten core that's moving.
Yeah.
and you have the plates that are moving on the molten core. And it takes me right back to Jerry Pollock and the fourth phase of water,
Yes.
where it streams.
Hmm.
That's so cool.
Just like that, my nasty little 4 o'clock alarm just went off.
I was going to say, that's the look that says my alarm just went off and I don't want it to, and
I don't want to go.
I don't want to go. It'll be okay. Oh, wait, let's see. Denise,
Did we answer everything before we go? Don't leave anybody hanging.
we do.
Okay,
And yeah, no, that's good.
we're good. All right. This was great. I feel like I can breathe again because I've seen your face and I've heard your voice.
Yes, and we arrived home alive and well.
Of course you did.
Yes, and then I'll call you more or less as soon as we get off the air. Thank you very much. Sorry, everybody.
We have secrets.
I love you guys.
Okay. All right. We'll see everybody next week.
Arrivederci. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.